Dimitrios Alexiou, the CEO of the Hospital Association of San Diego and Imperial Counties. Let's give him a round of applause. Sir, come on up. Thank you for doing this. I appreciate it.
Happy to be here.
Dimitrios changed a flight so he could be with us today. He was heading out of town, and he's like, yeah, no, I'll come. And we were reflecting on when we first hosted that LA conference in 2015, you and I met, you were on our convening panel, and you also were like, dude, San Diego is not LA. It's, you can't talk about LA issues. And we're like, no, it's Southern California. Anyway, so thank you for being here today. Tell us, just start us off, what would you say are the state of hospitals and hospital care in San Diego and Imperial counties in 2019 or 2020?
I would say a couple of things. First of all, good morning, everyone. Happy to be here. It's a changing environment. Things are definitely getting tougher as you look at reimbursement streams, growth in Medi-Cal, challenges with behavioral health. So folks are definitely strained more, I would say, than probably in the past. But that's not to say that things aren't also going well. There's still great patient care being provided, services when they need them, et cetera. So I would say it's sort of a mixed bag with folks looking to the future, and obviously with elections and things coming, that'll also help shape where we head.
Yeah. Some folks like Nick Mescione used the term of coopetition amongst hospitals.
Yeah, as I see Nick smiling over there.
Yeah, give him credit where credit's due. How is that changing, that coopetition, as the leadership in hospitals changes and turns over? Is that a culture amongst hospital providers that is unique to a leadership set, or is it more organizational? Is it geographic? Is there a shift in that as leaders in hospitals change?
I would say yes. Again, going back to where we sort of started, San Diego is just different. As I jokingly like to say, we got a base with Pendleton to the north, we got Mexico to the south, and Imperial County to the east, so we're pretty self-enclosed. We've also been fortunate in San Diego, when you look at leadership, the average CEO tenure is 3 to 4 years. We've had executives like Mike Murphy, who retired last year, and Dan Gross, who's going to be retiring, and Chris, who's been at Scripps. I mean, these are folks who've been in these places forever. And so even though it's a competitive market and you compete in service lines, there's a lot of places where you do work together. We'll talk about it, but behavioral health is one of those.
Yeah.
It's not something that anybody's fighting to say, I want to corner the behavioral health marketplace. Yes, they want to meet the patient's needs and provide great quality care, but that's where there's opportunities to collaborate and cooperate, better cooperate in those spaces.
So it's good that you mentioned that there's a lot of energy around BH. Mm-hmm. Give us a summary for people who may not sort of know where we're headed about where things are going on BH. And I'm going to use that to follow up with how did we get here in the first place?
Yeah.
Start with the first question.
Yeah, so, behavioral health is an interesting space. I don't think anyone would say we've got this great and there's no one county that has perfected it. What we've seen in my 5 years here is a growth in the county's budget. Thanks, Nick. There is more spending going on there. But the challenge is that, the more you spend, the more you realize how much more you need to continue to spend because there's a deficit. We've seen, some shrinkage in the number of inpatient beds. We still have the second most inpatient beds in the state, but that's not to say that is enough. We look at our post-acute care network. There's significant challenges there. So there's a lot of opportunity, and obviously San Diego's been in the media with some hospitals closing some units and some challenges around homelessness, et cetera. Not to say homelessness is behavioral health, but obviously with the homeless population, there's definitely a significant subset with behavioral health conditions. So, it's what you see is some definite challenges. And it's also one of those spaces, just in the larger sense. We have parity regulations at the federal level, but there's still opportunity there to better have parity between physical health and behavioral health, because I can tell you, as we currently sit, there isn't.
So what do you think the magic recipe was that got the San Diego region into this behavioral health deficit, particularly in the inpatient side? Is it a lack of awareness? Was it a lack of funding? Was it a lack of payer and county relationships with providers? What were the sort of unique things that led to the media attention, and how do we avoid that moving forward?
Yeah, I mean, obviously, I would say first and foremost, it is a challenge. Regulation definitely factors in with ligature regs. Not to say those aren't the right things. Obviously, you want to keep patients safe, but anytime you have a service line that is underfunded in terms of reimbursement, and then you layer onto that more regulations, which adds more cost, it's sort of perfect storm to see some changes in availability.
Give us an update on how some of the hospitals are stomaching and getting through earthquake preparedness and regulations that some of these buildings need to be retrofitted to pretty high standards.
Oh, well, yeah, I mean, obviously we're fortunate or unfortunate here in San Diego and California. I mean, obviously we have earthquakes and it's something we have to prepare for, but it's a challenge. I mean, those are huge unfunded mandates to the tune of hundreds of billions of dollars. And, you know, when you talk about, to touch on what Beth just touched on, you know, what do people care about? You know, you talked about Medicare for all. I would argue it is an affordability conversation. And when you're spending hundreds of billions of dollars that don't go directly to patient care but are going to buildings, you're not addressing what the core issues are, which really gets back to providing great patient care and acknowledging that healthcare is evolving. You know, more business is provided in the outpatient side than the inpatient side, and yet we have regulations that keep you to these inpatient buildings where if you were building something today, you wouldn't build a 500-bed hospital in a tall tower. You would build things differently, and yet you still have to meet these regulations. So, you know, you factor all that together, and it just creates some challenges with areas like behavioral health that are important.
One of the big topics on the radar screen for 2020 and maybe 2021 and maybe forever, but certainly 2020 is how to reshape Medi-Cal and what that feature and at some point RFP and procurement process will look like. San Diego County is one of two general managed care counties. It's got a lot of players in that space, underperforms in terms of HEDIS scores. What would, since it's just you and me here and there are no plans, no plans in the room, what would you like to see? What would the hospitals like to see in San Diego and Imperial counties vis-a-vis that Medi-Cal reprocurement? Should we have fewer plans? Should San Diego have one plan? Should it just be two? Should the county get into the procurement space? What are your, I know you guys must have consensus on this.
Yeah, it's just you and I here, right? Right. I mean, Brianna's sitting there, Nick's over here smiling. You know, I think those are challenging conversations. I mean, obviously CalAIM's something that's out there looking to reshape Medi-Cal and standardize it. Whether that goes through or not is dependent on the federal administration, who isn't looking to do California any favors, but the procurement process is going to be interesting. I mean, we are unique in San Diego, having 7 plans. No other county has 7 Medicaid plans. We also have a significant Medicaid population. I would say there's opportunities. I mean, you're referring, I think, to the CHCF report, which recently looked at, you know, when this all started, the expectation was you'd have better quality, better network adequacy, et cetera. And according to the report, that just hasn't been realized. That's not to say you throw everything out, but I'd say it's going to be an interesting process once that procurement's released. And then I believe the final decisions are made in like 2023. So it's still a few years out, but there's a lot of conversation there. I would say from the hospital side, it's challenging. Just getting back to where we're at, we also have a bifurcated market in that behavioral health sits over here, physical health sits over here. So you can't put it solely on the plan, solely on the county. I'd say there's got to be some agreement on how we can provide better care for the whole person as opposed to siloing these things, and you know, just a procurement process doesn't solve any of that.
I tend to think that cost is the preeminent issue of our time in healthcare, and that we have a lot of issues, but that's one that's driving a lot of backlash. Hospitals remain, generally speaking, between 50 and 55% of a premium, depending on how one wants to break that down. Pharmacy costs are certainly on the rise. Pharmacy and hospitals are, generally speaking, far less regulated in terms of profit vis-a-vis a health plan. They have plenty of regulations, there's no doubt about that. But some people would argue that it's time to regulate pharma and the profits of pharma, and to regulate the profits of hospitals, whether they're nonprofit or profitable, and that you just can't get to addressing cost without some sort of rate reimbursement mechanism for those entities. What do you make of that argument?
That is a large question. You see some states, I want to say Maryland and others, where they've done that, but you got to also look at scale. Maryland has, 50, 60 hospitals. We have over 400. We have, 39 million people. I would say there are opportunities, getting back to the affordability conversation, to do better.
Yeah.
But it's, again, goes back to structure. I mean, a lot of the cost piece gets tied up in these large hospital bills, which really go to charge masters and things that aren't relevant in the larger piece. If you want to address a lot of these, you really got to look at Medi-Cal and Medicare rates and pay relative to what the things actually cost. I think that will help shift a lot of that. But, there is a large conversation around affordability that is definitely coming.
You mentioned Maryland. As you know, the current CHA, California Hospital Association CEO, had been the hospital association leader in Maryland. Is she bringing any of that conversation from Maryland and changing reimbursement to the California hospital members?
I would say, I don't know that she's bringing it, but it was interesting timing, because you had a bill last year, I believe it was, that was looking at the Maryland model, but it really wasn't the Maryland model. It was far from it. I would say there's opportunities to look at all states and see, are there things that other states are doing that could translate to California. So I don't know that it's intentional that we're trying to turn California into Maryland. I think we're just, as a state, looking at where are opportunities to provide better care and affordable care.
Yeah. Would you argue for, I think San Diego, we've established it's a unique ecosystem. I think that there are some opportunities for leadership and reform that exist in San Diego that don't exist anywhere else in the state of California, because in part of the relationships, the unique geography, the kind of captured system. Should San Diego argue for a unique model, a different model that would allow for some of these payment variations or different models, like maybe the Maryland model or some sort of community-based payment model? Should San Diego argue for a different approach here in the next waiver process through this Cal-AIM process? Should you all go to the table and create something new that works differently here in San Diego because of the unique opportunities that exist here? Or is it better to continue to stick with one of the models that has worked for the last 40 years?
That's an interesting question. I think ultimately the devil's always in the details. I think San Diego is a unique market. I think we've seen that where we've been awarded a number of pilots in certain areas, whether it's whole person wellness, et cetera, where there's opportunities to provide care differently. Again, it would just depend, I would say. It's hard to answer a question without knowing what the details are to those changes, but I would say San Diego is positioned well to take on some unique things and try some different things.
Yeah. Do you know anybody that regularly gets a bunch of hospitals in the room together to talk about this stuff?
I don't know. There might be an association that does that.
Well, thank you for your leadership. Thank you for the stuff you do in front of the stage, and the stuff, more importantly, that you do behind the scenes. So let's give Dimitrios a round of applause, sir. Thank you. Appreciate it. Great job.